And ding, we've begun. This, bless you. This could be an uncomfortable topic in a lot of ways. I don't know how to frame it, and you're gonna have to forgive me. I mean, I know you're studying. Are you done with male and starting female, or you're still doing male? So I mean, it's uncomfortable. It's difficult because this is unfortunately the kind of stuff you begin to confront relatively early on these days, comparatively speaking. And again, thankfully you are much better educated about these things than we were, but and realistically, people, it's very hard to deny biology. It's just such a strong motivator, and Lord knows I am an authority on this because I'm hopeful that none of you had children before you were 16 years old, right? So I mean, and this is who you're listening to. Somebody who I had an 11-month-old great grandson we had for 2 days this weekend. If I'm a little crazy, there's a reason. He's toddling. The poor dog, when this crate goes, enough. I want nothing to do with this. The cats were toddlers. I mean, we're enlisting babysitters just in case. Just what I wanted to do during my summer. Yeah, it's okay, but I digress. So I mean, it's extraordinarily important because realistically, I think after respiratory, we are confronted in our lives, perhaps more this than anything else, with genitourinary infections. They're extraordinarily common, and thankfully, most of them are the ones that are relatively easily treated. It's the one that potentially could kill us or cause long-term problems to ourselves or to our children that are particularly relevant to discuss. And from a standpoint of not just personally, but as a caregiver, as someone somewhere in a clinical field, as many of you aspire to be, this is you're going to see this. There's a lot of teaching that has to go on, and sometimes it's a very hard topic to broach. But all that with the introductory remarks, more or less here. The male, I've always found the male anatomy to be a little bit more complex. There's a lot more structures, and the female, although simpler, the physiology is much more complex, and because of the anatomy of the location, as I mentioned before, the anatomy of the area makes it much more predisposed. More or less, the short urethra is probably the dominant. But just look at the location of the urethra, the vagina, and the anal orifice, all in such close proximity. Just all those vital structures right together inevitably are going to lead to a massive number of infections. So that's it. So you talked about the blood testes barrier, I hope. Ringing a bell. Sperm, yeah, because if something traumatic happens in that area, so in a sporting event, and there's a rupture of one of those structures, say in the testicular area, all of a sudden those sperm go out. The sperm aren't produced until after puberty. Your immune system views them all as foreign, and so there's a massive immunological attack, for instance. So that's one of the problems that potentially is attendant to certain kinds of infections, just as an aside. But again, in the female system, the big difference is it's effectively not a closed system because those eggs you're born with. And so that immunological phenomenon is not quite there. The problem is when the egg is ovulated, it can go into the abdominal pelvic cavity. And so there's much more of a case of ectopic pregnancies. And ectopic means just something that's there that is in the wrong place. Doesn't mean it's not part of your body, but it's just in the wrong place. An ectopic focus, and like in the heart, if all of a sudden the pacemaker is someplace else, we call it an ectopic focus. It's ectopic, E-C-T-O-P-I-C is an important word for many of you going forward. So yeah, they descend, it's warmer, it improves sperm production, that's the physiology you get. All of those things, antimicrobial properties, they're all part of it. So because of the sexual pathogens that can infect, okay, there's a lot of problems attended, and it's the length of the urethra, of those structures, that allows this to be, and typically it's much more noticeable because although that's a comparatively long journey to get to vital structures, it increasingly becomes more and more symptomatic. More on that as we move on. In older men dealing with prostate. You don't have to worry about it. More than half of you guys It's good. It's coming your way. Okay. In what was it, October 21, I had to have not for cancer, but just a large prostate resected. Not fun. The procedure is relatively easy. It's the aftermath that's not fun. It's just okay. And moving on. Microbes of the genital tract affected by hormones. We mentioned that. This is again is the big player. Your big protector is lactobacillus. The glycogen deposition by estrogens converts lactobacillus to lactic acid. The acidic pH, that's the protection during the childbearing years. Other than that, it's mucus. So lactobacillus, additionally hydrogen peroxide, and that assists with anaerobes. And there's a lot of anaerobic bacteria or organisms that flourish in a low oxygen environment. Particularly certain kinds of streptococci are found in that area as well. It's particularly interesting in that regard, which brings us to probably the most uncommon thing, the most common of them all. First, on the hip parade, these are classified as non-sexually transmitted infections. Even in the presence of an active infection, it'd be very unusual to transmit it to a partner. Just saying. I mean, it would be very, very unusual to do that. Just isn't the way it works. So we call it cystitis. Cyst, C-Y-S-T, is for the bladder. The most common agents by far and away, E. coli, probably second on the hit parade. Another one you're working with in the lab, Proteus vulgaris. Okay, those are normal gut bacteria, and that for whatever reason, whether it's hygiene, whether it is indwelling catheters, whether it is people who are, unfortunately now bedridden, pick any one of a zillion reasons. Some people are just more prone to it. Okay. They used to call it honeymoon cystitis for, let's say, an uptick, relatively speaking, in the amount of sexual intercourse someone would have at a period of time. But anything along those lines, all those things predispose people to it. And so a lot of times it's not that noticeable immediately. But typically these are, and this is uniform for men and women with regard burning, frequency, urgency, discoloration of the urine, all of those types of things are really noticeable. White blood cells usually make for cloudiness that are there. So you get a tremendous amount of information. I just finished this unit with my advanced phys people. Urine is it's a non-invasive test, relatively easy to collect, and you get a lot of information, whether it's about diabetes, whether it's about immunological events that are happening. So it's very, very useful. And again, the color is different. If it's frank blood, that's different. If you're peeing red, that's a big problem. The vast majority, if there isn't a traumatic incident, and certainly that would be a reason for it, the number one thing, and I had this, everybody, cancer, bladder cancer. Big tell. Number one. If that doesn't get your attention, and Lord knows it got mine, and I am a bright enough person that this happened to me initially in 2003 when it occurred, and it only took me another 5 years to stop smoking. That does get your attention. Okay. Other things like the odors sometimes can be different than what one is used to. Suprapubic, meaning sort of above the groin area, anteriorly. And then all of these things, it's a plumbing problem, ultimately. Men or women, starts to go in the wrong direction, back to vital structures. So in the female, we're working our way up, and because of the proximity of the urethra and the vagina, now we're dealing with potential of pyelonephritis, really significant problems. Typically kidney, low back pain, flank pain. Those are little signs, warning signs about kidney-related problems that are there. All of those types of things, and obviously if it's not treated, they're treated relatively easily. These agents that we now use so commonly are very, very, very effective. We use them very, very commonly, as I told you, for MRSA, and they're just remarkably inexpensive and very easy. The trade names are Bactrim and Cepra. It's those combination sulfa drugs, sulfamethoxazole and trimethoprim. You remember that from antibiotics a little bit. Skip out. Don't flip out. You only have to take one of these tablets twice a day. Get used to that. Tabs 1, BID, PO, twice a day by mouth, typically 4 times. Time for many of you to get used to reading doctor handwriting. It's an art. They teach us in medical school, there's a course called bad handwriting. And you have to learn how to do it. And you've seen this, living proof. Considering how many of you are here, it would be nice to have a little bit of a response finally. Like, by and large, weren't you happy with the grades on the thing? Okay. A nice smile would be nice. The occasional pleasantness. But no. All I'm seeing is, what, did you have a test upstairs? Well, the door was closed. Help me. I'm a little crazy. It's the first time I haven't been able to stop talking baby for almost 48 hours. Bacterial cystitis, causative agents, normal intestinal microbes, 80% uropathogenic. They have a tendency to adhere. Those neat little fimbriae and projections, that's how they adhere. Good old E. coli, all of these. Klebs, Proteus. This one's interesting. We're seeing an uptick in Staphylococcus saprophyticus. There's actually a way, there's a particular disc that you use to test for it. Maybe you'll learn about it if you're learning more about this, depending on the area. Cause remaining infections in young women, much more so than in younger women. We're seeing an uptick in this. It's a Staphylococcus strain. It's an interesting strain. Catheters, and that's where we get into oddballs. These are Serratia marcescens. Did you have that in lab? Did you have one that turned red when it was sitting in the culture plate? We have that here. It's a fairly safe bacteria. It's not a problem. What the tell about that on a culture plate at room temperature, it starts to get red pigment throughout it. And it happens to be gram-negative, but I'm talking about grossly, not microscopically. Pseudomonas, Enterococcus fecalis. Again, most of these are either normal flora on the skin or surrounding tissue or gut bacteria. And unfortunately, this becomes the problem. Some of these oddballs, particularly Enterococcus fecalis, very difficult to find antibiotics for. Okay, these are those pili or fimbriae that attach. Okay, that's what the acronym UPEC, I don't use it. And all this enter the underlying by endocytosis, bacterial communities, move into the bladder, create all of these areas that are there, chronic reservoirs in some folks. That's why I had a lot of patients. I was very, very aware that these were potential problems that were there. Okay, anything that inhibits the flow risk. 1/3 develop lifetime. Some are more proof. The short urethra, sexual activity, particularly indwelling birth control devices or different kinds of birth control devices, diaphragms, barrier methods, that type of thing, probably could add to it. Okay, other factors in general. So we even see this in the male. They get prostatitis, okay, which I had a case of, which is extraordinarily unpleasant. Catheterization, paraplegics, because inevitably there's problems with being able to urinate. There's frequent amounts of catheterization, etc. Depending on where you are, you become familiar with all of these. It's very, very, very interesting. Okay, typically it's not a long course of antimicrobials. If it ascends, big trouble. All of these things. You're going to see this continuously throughout. Appropriate hygiene, urinating following intercourse, flushing the system. Water is great. Urine is a flushing agent, for lack of a better way to describe it. So these are important things to you. Okay. Other things, low doses of antimicrobials. I don't find that to be, I don't know if anybody uses that. Okay, a couple of things. The inconclusiveness. This lady is a nephrologist, moved on. I actually used to tutor her kids before I got my full-time teaching gig underway. And I asked her about and she goes, I use it all the time. Nephrologist, brilliant woman. And she over at AGH. And she basically said it acidifies the urine. See, certain things accumulate in the urine. That's why cigarette smoking. Some of the carcinogenic agents accumulate in the urine, hence the predisposition for bladder cancer. Why cranberry juice is useful for all of those types of things. It more acidifies the urine. Bacteria don't like an overly acidic environment, period. The green tea, I don't know enough about, but again, anything that induces increased amounts of fluid flow through there have got to be useful, I would anticipate. And that's, I mean, you can read this just as easily as I can. They always include these on these PowerPoints. It really has to do with contamination in water if people are using that to bathe. And generally, it's something that's found in animal reservoirs, and so we don't necessarily see it, as I've described to you before, a relatively pristine water supply. But if you think of other areas where people are bathing in the river, bathing in lakes and things like that, and the animals are using them as well for a variety of purposes, voila, leptospirosis. I'm not going to ask you about it because I've never seen it, don't know enough about it. It's a spirochete, and you're going to see spirochetes are interesting because of sort of they typically have first, second, and third cases. You can read through this. I used to go over this. If an animal is going to the bathroom there, my advice to you is to avoid it. Okay, it's really all about that type of things, because you can see normally, if with appropriate treatment, it's relatively limited, but medical treatment is part of this. This is what it looks like. It's one of these gram-negative spirochetes, and so tiny. It doesn't preclude swimming in a pond or swimming in a lake or anything along those lines, but breaks in the integrity of the skin are a problem. So that's something you have to be watchful of. And again, after doing that, I would, you got to shower and bathe after those kinds of things, I think, would be the way I would tell people, because it's what you're going to do. I mean, my kids were creek walkers and all that type of stuff for years. But we just do not see it around here. Much more tropical, wild and domestic animals, contaminated urine mostly. This is one of the problems. My stepdaughter did a college thing in Costa Rica for one of these, like we have FLEEPs here, these learning experiences overseas. And the only antibiotic they told her to take was get a prescription for, and I think it was like a prescription for Cipro, because it's good for gram negatives, because they're going through rainforests, it's muddy, it's wet, your clothes get like that. And if you start to develop any of those kinds of symptoms, boom, have that handy. And also it works for the water supply as well. So that's the best I can tell you about that. I'm not going crazy. Okay. These are the kinds of people who are much more prone to it, using if they have to do is constantly, either occupationally or recreationally. That we're there. Thank goodness I'm done with that one. As much as I want to talk about it, there will be no questions. See? Vaginosis. This is one of the first ones that's difficult to talk about because it's stigmatizing. A lot of things stigmatize people, particularly when, in this case, it has to do with an odor that most people have described as unpleasant or, quote, fish-like kind of a smell. It has a bubbly discharge, and that's a little clue. When we start to see bubbles, we think anaerobic activity, fermentation. That's there. It's a vaginal discharge. The color is varying that are there, and it's super dangerous. This is what happens with almost anything that affects the female genitourinary area, particularly. We basically, it will ascend. It gets to the uterus, into the tubes, and you get this name that you're going to hear over and over today and going forward this week, PID, or pelvic inflammatory disease. It's awful when you see the examination of someone with it, because a lot of times it's not that obvious clinically until you do a pelvic examination. And it all has the same problems: ectopic pregnancies, sterility, early hysterectomies, and possibly septicemia going throughout the whole system. Very scary. And you're going to see me repeating myself about this. And a lot of them are asymptomatic. So we really don't know. And because of that, I think the frame is the need for, I've said this to a lot of classes, for most women, I would think if you're going to see any doctor on a regular basis, it should be whoever does your OBGYN work. whether it's an OBGYN, whether it's a family physician, whether it's a nurse practitioner, whoever you're comfortable seeing with this. That I think really the reproductive health is really an area where there's potentially a lot of problems. Causes are unknown. We know it's associated with lactobacillus, okay, when it's not there. There's lots of bacteria that are very, very difficult. It's just a combination. This is something, changes, losing the acidity, the pH really, this is normally a fairly acidic environment, disrupting the microbes. They call them clue cells, which is a relatively large cell that has specific things associated with this. They say vaginosis means condition of, because it's not usually inflammatory. That's why sometimes it doesn't go noticed. Maybe if there's a discharge, it's dismissed as something that's being normal. Or again, if someone's uncomfortable because of the odor, and that's why we think about anaerobic. That's there. Not well understood. Sexual activity. This is interesting. I've read that a lot, not just in the PowerPoint. Sexually abused children, pregnant women, all of these things. Multiple sex partner, sex with other women, new sex partners, IUDs, etc., etc. And again, there's no proof of sexual transmission. Those who are not sexually active at all, very unusual to find it. Okay? And this is a recurrent theme for this whole chapter. When you are infected with one thing, anything that disrupts the normal area for whatever reason, whether it's the normal microbes, whether it's the pH, whether there are small irritations or inflammation, all of those disrupt barriers. That whole immune system thing, I didn't do the immune system because I didn't do AP2, but that's your protection. And anything that disrupts it, everybody, for whatever reason, whether it's irritation of the skin, whether it's the presence of genital urinary lesions that we'll go on to discuss, like warts or blisters, anything that does that, just like this, really increases dramatically the potential that you could have problems. And we're not even going into stuff of protected versus unprotected and new partners or multiple partners and blah, blah, all that. But I don't mean to be preachy. Yes, I do. Because I'll tell you what I'll frame it in a second. So all of those things, and this is true with infected men with another problem. Higher risk for getting any other types of things. Once you have one, the chance of getting multiple ones is greatly increased. And it doesn't have to be one STD. It could be one of these not presumed non-sexually transmitted. Your level of risk increases dramatically. So antibiotics, but can be recurrent. So there's apple treatment. Most of the time we think there is, and this is important. When I say that, that's code for it's likely to be on the exam. Got it? Because we think it's anaerobic, has some type of anaerobic component. We think it has something to do with something called Gardnerella, which is an anaerobic bacteria or functions better in anaerobic environments. We utilize metronidazole, flagyl. Many questions coming your way again. I emphasized it on that exam you just took at home. Metronidazole or flagyl is a weapon we have for things that have anaerobic metabolism, and they aren't all bacteria. So all of those types of things, prebiotics, probiotics in this case, yogurt, other types of things that you could utilize with that. They're easy to come by these days. We're constant. Okay, and you're going to see these. You're going to see this abstinence, number of partners, avoiding douching in that particular thing. It doesn't involve male sex partners. All this stuff. It's there, and there's a lot of unknown, all the types of do's and don'ts that you're going to see. So I mean, this is the detective portion of it, trying to find out all those types of things, questions that you might certainly would be uncomfortable if someone was asking you, but many of you are going to be tasked with it. That's part of the history, asking those uncomfortable questions. There's a way to do it. If nothing else, there's an art to it. Trying to get people who are willing to talk to you. I've always flattered myself in thinking I'm easy to talk to. Maybe some of you feel that way, maybe you don't. but it's just something that one gets being coming off non-judgmentally. I know this is very preachy lecture. But yeah, I've been doing this stuff for a long time. It just drives you, and that's the hard part because of the patient, patient confidentiality. I mean, many years ago, I mean, that's why I like being in a situation here where I knew that it was a minefield, because if you're teaching in public school system, if a student comes to you and goes, I just have to tell somebody, you got to tell, you can be compelled to testify that in court. When it's patient confidentiality, it's a little bit different. So there are things like that. And I'm sure they'll go into the legalities of it vis-a-vis, for many of you from a nursing perspective, just when someone feels compelled to tell you something, it's so important. And this is one of the areas we hear a lot about that type of stuff. Things that you have to go through. So I really feel that need to share it. Before we get to the STDs, and I'll frame it differently. So that was the vaginosis. Here's extraordinarily common. This is vaginal yeast infections all the time. These itis, okay, this is what we typically call this bacterial, not bacterial, but vaginitis more than vaginosis, okay, almost inevitably candida. There's a new strain of candida in the hospital, which I forgot to tell you folks about, but I remembered for the other class because we were talking about it. And I know my spelling is awful. This, Auris. So AURs would strike me as there'd be a golder color. Albicans is a white color. It's like Staphylococcus, okay? Aureus and Staphylococcus epidermis, which used to be called Staphylococcus. Emerging, multi-drug resistant. Facilities worldwide, notoriously resistant, particularly diflucan, which is the big player we use for bacteria. Some strains resistant to all the three main categories. Surfaces, high mortality outbreaks, often targeting ill patients. I would urge you to just do the Google search that I did and look at these things. This is a player. So one of my colleagues, and I had read this article about it in one of the journals I look at a while ago. I just had forgotten the name. One of my colleagues, who's Dr. Buxton, who teaches physics, happened to mention that to me, and something he's, of course, his path and things that he had read. Bang! I figured I'd better mention to you guys. And I did mention to the other class, not that we had covered this unit, but the fact that it was kind of there at that time. So as we move on, these are almost all Candida albicans. The discharge is more white. Sometimes it'd be clumpy. It's again, a third, maybe to a half of us normally have Candida albicans orally, vaginally. It's part of normal flora in many cases. It's not abnormal. I suffered from thrush when I was taking immunosuppressant drugs. I had to do throat lozenges. I may have told you that 5 times a day. That's the modern treatment. It's fairly effective. I mean, so as long as I don't have to go back and do a lot of immunosuppressant drugs, because when your immune system is suppressed, something normal can be a problem. And we see this almost exclusively with broad spectrum antibiotics because they clobber lactobacillus. When the lactobacillus is not doing its job in producing acidity, this can flourish. Basically what happened. Usually limited by this lactobacillus, immune system, anything that can disrupt this balance. So sometimes more common during menstruation, pregnancy, oral contraceptives, a major player. Antibiotics can allow multiplication. Diabetes, this is where I saw it mostly. All of these types of things are part of this. And again, while those are there aren't always, I mean, the majority typically don't have those predisposing factors. We do not consider this to be spreadable, because this is more inflammatory that's there. It's almost always Candida albicans. We rarely culture for this. Normally it's just a clinical presentation. and using, typically you could use topical drugs by, basically some type of applicator. It was much easier for me to use fluconazole or diflucan. Again, another one. This was the one I mentioned to you with toxic shock. It's in this unit. I had just started in practice in 1979. 1980, all of a sudden, I'm beginning to think it was within the first year of my practice, all everybody could talk about was this stuff. People dying, and they finally made the association with that high absorbency tampon. Not a new disease, but it emerged based on the technology, all faulty. The tampons were basically much more common than sanitary pads or sanitary napkins that were there. Bad. I mean, this was one of these super antigens. All those you may have talked about it, super antigens, hyperactivity. I mean, basically, your helper T cells, 20% of them going crazy, producing cytokines, called a cytokine storm. All this bad stuff occurs without treatment, blah, blah, blah. Awful. And although it's streptococcal, this was much more commonly the problem. Now we don't see it from the tampon use. When we see toxic shock, a lot of times it's from injections and people who inject themselves unsanitary. So you can think of drug users. You can think of people injecting performance enhancing drugs on others, people who are untrained doing it. There's all sorts of stuff. And I'll comment on it as well. Let's see. Try to get through this. Just with a culture plate, cytokine storm. This particular toxin, 75%, certainly not communicable, etc. And severe. It's pretty much standard stuff. Okay. Now we get to the STD part. Thank heavens. You guys are much better informed for your age. It was, and probably your parents were like that too. But folks who are your grandparents' age, like anybody sitting in this particular chair right now, thank you. You're in such trouble. Again, another opportunity. You can't be that old, but yet, once again, after I was nice to you on that exam, so you're really treading thin ice with this final. You all have to know that. Don't look at me like that. It's my last shot to get even with you. So don't F up. We knew nothing about this. I don't know where the education came from. We didn't get any. This was taboo. We are what's called a very provincial nation. Oh, we don't talk about that at the dinner table. That kind of stuff. Our parents, we didn't know. We didn't see a pregnant girl in school. Ever. Somebody was always going, oh, they're going to go away and live with their aunt for a year. That's what we did. That's what we got. So this is the nature of what happened. Why when you're, tell me why our nation, as surely the most developed nation on earth, has this extraordinarily high, disproportionately high rate of sexually transmitted infections. It is still, in a lot of areas, very reluctant to discuss, where it's commonly discussed in Europe. We're a relatively young nation. We haven't gotten to that point. And it hasn't changed that dramatically over the last 25, 50 years. Thankfully, in a perverse kind of a way, and I use the term advisedly, for HIV, because all of a sudden, people didn't do what we did. What happened starting in the early 60s, there was this interesting discovery called the pill. And all of a sudden, the ability to use, basically to have available some type of contraceptive agent that didn't involve using barrier methods, which would interrupt the process, if you know what I'm driving at. Okay. All of a sudden, we ended up with something and it was there, We had something called the Summer of Love in '67 that carried through for about 10 years. There. And people were prone to have what's called casual sex. So having one night stands was common. Again, the way I framed it, maybe I framed it the same way that you basically, don't worry. If you get something, the doctor will fix you. We had no idea realistically about how long-term complications, things that wouldn't go away, and things that you could be damaged permanently or kill you. We were extraordinarily naive. We all were. I say this to you sincerely. I mean, it's scary. So if I'm doing this to scare you a little bit, there's a reason. Because you're going to have that discussion with your own children, and you're going to have that discussion with your patients. You can tell them they won't. Sometimes people just don't listen. Biology is a very powerful thing. We weren't maybe too permissive in those types of things. Trying to think where our kids can make up our own mind. We were told that my daughter's bipolar had a strong association with early sexual activity. Well, guess what? That's why I'm a great grandpa with an 11-month-old great grandson running around our house and tiring us out. But we did sleep better. So that's the backstory. Here you go. The big problem, again, and excuse me for painting with a broad brush. The big problem is women are much more, in my view, this is strictly an opinion, pay much more attention to sexual well-being and sexual health. Reproductive health would be a better term, because they have babies. If they choose to. If they want to have children and want to have a family, they are much more attuned to it. And the big problem with this is you will see as a repetitive kind of a narrative throughout this. More than half of the problems in women are asymptomatic until they become a 5-alarm fire we call pelvic inflammatory disease. I didn't know there was anything wrong. And then in emergency room, we saw this repetitively. The physician would do a pelvic, examination, intrapelvic examination, and begin to palpate. Once they got into the area where the tubes and the ovaries were, oh boy, extraordinary pain. And at that point, there was always going to be damage. Now the risk of ectopics, the risk of infertility, the risk of forming damage there and resulting in hysterectomy was increased dramatically. And to try to convince somebody to make sure they take all the antibiotics and abstain and come in was just something we didn't see in the population we were dealing with, in an inner city population in a very poor area with a lot of homeless individuals. It was a big problem. And while things are considerably, where more than half the cases in men are highly symptomatic, they tend to be very reluctant to seek medical care. And they generally only seek medical care when they get to the point where the equipment begins to malfunction. When it becomes so unpleasant, that's about the time that medical care is sought after. I have no other way to say it. And that's a major conundrum that exists to this very day. But thankfully, we are much more aware of trying to be polite in the way I say this. We're aware of these things and has changed the nature of activity. That's the sermon for today. Okay. Many are asymptomatic, maybe unknowingly transmitted, varying by pathogen, but include all the ones we talked about. Vaginal urethral discharges, pain with urination, sores, rashes. They don't all have these. That's the problem. And in men, they're much more noticeable, and in women, frequently they are internal or not noticeable. Right. Some ascend, and once they ascend, we're looking at this, the acronym PID you'll become familiar with more and more as we continue with this unit, and some can become systemic, and some can be fatal. And some cause extreme damage to the unborn child and can be unfortunately passed on. There's an awful minefield with this. So it's a tough unit to teach. So I like to do this introductory stuff. I didn't know it was coming today this way. All of these things, whatever you describe as intimate contact. And today there's so many variables. So we're not talking necessarily about traditional intercourse. We're talking about anything that people do. And I'm not judgmental about it at all. Whether it's hetero, whatever words you want to describe it. I'm trying to phrase it in a politically correct manner. Okay. Whether it's heterosexual, whether it's homosexual, whether it's bisexual, you know, that everybody, you've got to do what's appropriate for your life and your lifestyle. You just have to be wary about it, and depending on what your approach is, be aware of the problems and be responsible and address them, and and seek regular care when it's appropriate. Okay, all of those things. Any of these areas are particularly predisposed. Most of these organisms don't do well on surfaces, thankfully. Okay, they don't survive well in the environment. So that is survival depends on how they mostly evade your immunological barriers. That's why when those barriers are disrupted for any reason, problems exist. Damage due to bacterial ones are usually due to inflammatory changes. And again, it's the old story. Bacterial infections, much more likely to have permanent problems, with the exception, which we discussed probably at the end of this, which is human immunodeficiency virus and AIDS. And I'll regale you with the story of being there once again before we even knew what it was. And I'm treating AIDS patients back in 1977, 76 and 77. Before the paper was written, before we had a name for it. Okay, and viral ones, more cellular damage per se. I never figured this one out. Just strikes me as it's easily transmissible. Absence of symptoms, open sores, inflammation, anything that violates a boundary. Go back and look at the immune system chapter. What constitutes boundaries? Your innate defensive. If those innate defenses are not intact for whatever reason, you are more predisposed to all of these. Fetuses and newborns, part of it, not particularly by the travel through vaginal birth. Also, things like we talked about rubella, crossing the blood-brain barrier, crossing the placental barrier. And again, obviously, unprotected sex would be part of that. So, bacterial STIs, more curable with antimicrobials. We're developing greater amounts of resistance. Virals cannot be cured. Nor the only antivirals, again, only work once you're infected. Again, how do we deal with that if immunizations are available? From everything I've been told, the Gardasil, it's been around for a fairly long time now, has been very, very successful. So, most reliable ways, all of these things you're going to see, blah, 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 blah. I'll leave it there, and we'll start getting into the more significant problems on Wednesday, and we will likely conclude this by Friday. Thank you. Remind me, if I don't send you the study guide, I'll send you the study guide. I'm sure I'll get that dictation out of the way because it's coming sooner than later. You're going to ask me anything.